pleased to have Dr. Diego Barreras with us today. Dr. Barreras has been a urologist at CHU Saint Justine and CHUM for over 20 years. He's a super specialist in pediatric urology, having trained at the University of Montreal and the University of Toronto. He has a strong interest in urinary tract reconstruction and neurobladders, transitional urology, and kidney transplantation. In addition to his role as a professor at the University of Montreal, he and his collaborators have published and presented more than 60 scientific papers. Dr. Barreras will speak to us today about transitional urology and spina bifida and the management of constipation, and the objectives of his presentation are to know the issues around follow-up and of neurogenic bladders for adults, awareness of the short and long-term risks of kidney function, to know the problems related to stool elimination, become familiar with the pathophysiology of stool elimination problems, know the pharmacological therapeutic approaches to stool elimination. Dr. Barriers, the floor is yours. Thank you. I'm happy to be presenting for everyone about transitional urology. It's a topic on which I've been working for a long time. When I started in Montreal, in Quebec, there wasn't really any platforms to transition patients from the pediatric world to the adult world. And often, even if it didn't exist yet, patients were found between two spaces with long times without follow-ups and care. And that was true for patients with spina bifida, but also with other congenital and neurological malformations, which are my specialty. So I'll tell you about that with an emphasis on constipation. I'm not a gastroenterologist, but in neurology, we have to manage elimination problems of urine and stool, and the physiopathology is similar, and the care is often done by urologists who also have an interest in elimination, stool elimination issues. And we speak to super specialists when with the basic treatment we don't have the resources to treat certain things. The objectives were presented already, so conflict of interest. I am a principal investigator for Allergan, as are my partners. Here is a picture of Saint-Justine Hospital. Some of you probably know it. It was enlarged recently. It has now become one of the biggest mother-child centers of the Americas, and we are very proud. And here is the CHUM, which is even newer than Saint-Justine, and it is one of the biggest hospitals in North America as well. So a lot of our patients go from Saint-Justine to CHUM, and that's where we follow them to. On this page, it's to show that there are many scientific papers and documents about transitional neurology, and it's true of other specialties. It's a subject that wasn't studied much in the past, but it's better known now with all the issues that we will mention today in the next slides. So, what is transition? It's going from the pediatric world to the adult world. It's defined as the ability of a person to take charge of their health of independently, to have a better and central role in decision, being as independent as possible from parents, and the pediatric structure. Of course, with all definitions, it doesn't include really everyone in all situations, but This is the essence of the idea that we had a child that was taken care of since birth for most patients with neural tube anomalies, and for all their childhood, they had a medical team, a multidisciplinary team, and their parents that made most decisions for them and would take many precautions. But now, this person, we give them the decisional power on their health and what they want to do. So we make them independent. And it's not always easy when someone has always been a bit dependent of a structure. So becoming independent is not always hard just for the patient, but also for the teams to succeed in doing this transition and giving more responsibilities to the patient. Below, you have a different definition from the American Academy of Pediatrics and family physicians. It says more or less the same things I just mentioned. So the transition from pediatric age to adulthood has been a problem for a long time, long-standing problem. It's linked to improving overall care. In the 60s, 70s, patients with anomalies of the neural tube, the more serious pathologies, and more physical disabilities and intestinal issues did not have the same life expectancy as they have now in 2022. So it was a problem that did not have the same importance because, unfortunately, people did not have the same life expectancy. But now, with spina bifida, in the past we could compare it with cystic fibrosis that had a very short lifespan, and now it's longer. So this has caused problems for teams taking care of adults because they didn't necessarily have experience or expertise on the question. But today, almost all children with all spectrums of spina bifida will move to the adult world. It's very rare that there are serious complications and they don't make it to adulthood. So I won't go over this in detail. It's in English. It's an article that was published just last year. But you have everything that's involved in transition in the point of view of the patient, but also the point of view of doctors and treating teams and families. What makes it difficult? In general, there's a big link that is developed sometimes between even before birth when they received a diagnosis until adulthood. There's a strong link with the medical team, with the parents, the doctors, the therapeutic team, urology, the orthopedics, neurosurgery. There's physiotherapists, a pediatric doctor. So there's this whole team that sees the patient on a regular basis and takes care of all the aspects of the children's health. So there's a very strong confidence link. So it's hard to think that you have to find a team with which you'll have the same link. So it makes this transition difficult. And we're all the same. When there's change in our lives, whatever area of our lives, it creates anxiety. So that's part of what makes it difficult as well. And also the lack of information of what's available, the resources that are available, where to go, when we make this transition. It was often nebulous, and patients didn't know where to call. Do I call my doctor? Which clinic, which hospital do I have to call? Who's going to take care of me? So just this was a challenge. So all this, course, causes anxiety, but also makes patients more vulnerable to complications and problems with mental health.
À devenir évident qu'on aurait des patients
When it became evident that we would have a lot of pediatric patients who would become adults and needed to take care of it, it actually created quite a lot of issues. The resources and investments as far as chronic disease are actually very poor still. We have been talking about these things on TV, and the resources outside the hospital are quite limited, and it varies from country to country. But globally, we invest a lot of money in acute diseases, but not as much effort in chronic diseases, and very often how these diseases bring people to the hospital, and we could avoid this. So there's a mentality that we would need to change as far as chronic disease is concerned. Of course, there's a lack of expertise. I've talked about it earlier. There are not many urologists, adult urologists who have uh, developed training. I have the opportunity to work with Dr. Jolivet. She has training in neurological bladder, and it includes spina bifida. And over the years, she's been working with me at Saint Justine, so she gets to know the patients before they get to adulthood. So it really helps the transition. And also before, even if it less a problem now, there was a lack of communication between children's hospitals and adult hospitals, because the Canadian system, everything stops at 18 years old. And so there was a rupture in the services between the organization. Here at Saint Justine, we've had a pretty liberal approach. So we've had patients who were 19, 20, 21. So we were stretching the pediatric stay. So of course there were some inconvenience because it's not a hospital that's thought and designed for adults, but it did help with the transition and the transition to adult care. Another thing that was problematic is that kids are different from adults, and the management or the is different. As a clinician, we take care of kids a little bit as though they were our kids. So we're adding up to the parents as far as how we do things in our considerations, and the social aspect that is heavier in pediatrics than it is in the adult world. There are pros and cons to this, actually, because when we manage in a more holistic and intense way, sometimes it does hinder autonomy for a patient who can actually do their thing by themselves. So we need to take this into consideration in pediatrics. So now, what are the consequences of having a bad transition? There are several studies that have shown that the patients that haven't been well taken care of or sometimes not taken taken care of between two worlds, and they can have complications, and they can come more often to the hospitals and to the emergency room. And at the emergency, we take care of acute problems, but not all the problems. And very often these patients need care of different specialties. So because of this, there are more surgeries that are being done because of complications. We've seen that 56% of patients have required a surgery during this transition period. Sometimes there's a kidney failure because there can be also a loss of bladder and bowel control, fertility disorder, a loss of autonomy, and social isolation as well. And so some people can isolate themselves when they're not taken care of properly. What are the solutions now? Actually, there are solutions. Even if it seems like it's a quite difficult picture, people organize themselves. There's the neurological bladder has not changed very much in 100 years. There's a principle that we were evoking 100 years ago: optimize bladder emptying, reduce the risk of infection, protect the upper urinary tract, prevent, recognize, and treat the complications before they become irreversible. These are all principles that were actually put forward more than 100 years ago. I put the reference at the bottom, and what we do in 2022, it's actually quite close. We maintain the renal function. There are vesicle problems also, and other problems that spina bifida patients have, and we want to avoid dialysis. And we also want to improve the quality of life by maintaining optimal urinary and fecal continence. And this definition comes from the patient. What is an adequate bladder and bowel empty? What is something that is suitable for the patient? We have to ensure adequate bladder and bowel emptying, take care of problems linked to sexuality and fertility. Now there's a life expectancy that's much better than before. So these are things that the patients are looking at and asking themselves about. And in the past, it was not so much the case, but now fertility is part of people who have a spina bifida, and we can really go around these problems. So we tackle this problem more. Also, we regularly monitor possible changes in function in order to treat adequately and avoid complications. And also, in the past, we used to think that kids with neural tube disorder, they were stable and their state was chronic. But unfortunately, we age, and with aging, maybe it's not just aging, but there are some anomalies as far as how the bladder functions and the digestive tube. So the changes can happen. So we need to monitor and really follow up in a regular way to avoid surprises. Sometimes we can prevent surgeries if we have a good follow-up with patients. Now, the model of the CHUM and the Saint-Justine Hospital, actually, it started when I started doing follow-up clinic with adults a few years ago. At the beginning of the year 2000, one of my teachers, professors who was working in the older version of the CHUM, he came up to me and says, would you be interested in doing adult urology with us and take care of complex cases with different pathologies? And people didn't really know what to do, and there was a need for this. And I thought for sure right away, I said, yes, I'm interested. And at the time, very few people were taking care of this. I'm one of the first ones in Canada, actually. This is how the clinic appeared. And then Dr. Jolivet started to work. We worked together, and she works in Saint-Justine. I worked at the CHUM, so we have combined clinics. And most of the patients, the spina bifida patients know Dr. Jolivet and myself. And they were at Saint-Justine before transiting to the CHUM. So this is the model we've put in place. Some places have only one urologist working, but I think we need models with more than one urologist. Patients need to accept to work with more than one person, because if there's only one person and this person for some reason is away or sick, or then we have a system that's problematic. And so what do we do as far as follow-up with patients who become adults? It actually looks quite like what we do with kids. There's at least a follow-up every year. Sometimes it's every 6 months if there are changes. So we'll have a physical exam. We will do mictional calendar, catheterization, and we will do a stool schedule. We will also look at blood tests and renal function. And this also varies depending on how patients have evolved. We will also do urine analysis and culture. Some patients do mechanical discharge, and sometimes they have urinary infection, but we don't always treat them unless they're problematic. And we also do a urodynamic assessment. Before it wasn't done, but we would find them in more university hospitals, but we do them if there are clinical or radiological changes. If a patient was regular with the catheterization, if there's incontinence appearing, and then after follow-up, we realize it's not urinary infection, but there's a change in the behavior of the bladder. If the patient is taking regularly medication, then we'll do a urodynamic assessment. If the bladder is degrading, then we will do a treatment to protect the kidneys and improve continence.
Here there are models where we write our criterias, what we follow. It's from articles you'll have in the references at the end. Of course, many of our patients have bladders that are not rebuilt, but many need rebuilding or surgery. So when we think about when we have to think about that in adulthood, it's when there's uncontrolled incontinence Loss of bladder compliance. Compliance means the ability of it to fill up with a low pressure. So we have urodynamic studies to measure this when there is the right pressure for the bladder. If it's too high, kidney filtration may be affected, and this is where you'll have issues. So we want compliance. If there is a loss of compliance, we think about doing surgery. If there is a deterioration of bladder function, of kidney function, it must be protected. Sometimes it's the patient's desire to get reconstruction, or if they have issues with bladder emptying and catheterization, if they can't complete it. In the past, people would use ducts, but now we try to find another solution. Now, we talked about transition quite a bit, so let's talk about fecal elimination. This is a point of view of a urologist who sees a lot of patients with issues with their stools. So there's two main problems that arise. So bowel incontinence or constipation. So irregular emptying of the bowels or not at all. So between this high constipation and incontinence, you have a whole spectrum. Sometimes people experience both, diarrhea, uncontrolled stools. So we have to help them reach a socially acceptable fecal elimination for them. So often the patients will tell us what is acceptable for them. It's not up to me or to other doctors. It's the patients that will tell us what is acceptable for them, and we will adjust treatments according to what they want. So what causes constipation or fecal incontinence? Many problems will affect people with spina bifida. Sometimes it's a slow intestinal transit because it has abnormal neurological signals. So the movement in the bowels is not the regular speed. Sometimes it's a sensory issue. Sometimes a patient does not receive the signal to the brain to let them know that they should go to the bathroom. Sometimes there's a problem with the sphincter that cannot be controlled. So sometimes they feel that they should go to the bathroom. They can't relax the sphincter to let the stool come out in a controlled way. Or sometimes the sphincter itself doesn't have tonus and it's completely open. So that causes fecal incontinence. So depending on the pressure on the abdomen, that it can be affected, but it's not something that is controlled by the patient. And sometimes it can be a mix of all these issues, many sensory issues, or combined with a good transit, however. So as the caretaker, I have to adjust with the patient to find the best recipe. So with fecal matter, it's the same as urine. It has to come out regularly. It can vary, but in general, for an adult, it's daily or every 2 days. In some situations, more than every 2 days is okay, but for others, it has to be every day. But the idea is that it has to be done in a controlled way. When a person decides that they have to go to the bathroom, they decide to go. So regular fecal elimination, so it can vary, but every day or every 2 days is what we're aiming for, and a socially acceptable continence as defined by the patient. How do we reach this? Of course, the most important thing before any treatment is to make sure that we have a healthy diet with a good fiber and fluid intake. Many patients limit their fluid intake because they have a lot of urinary incontinence, so it's logical to do this, but in general we want them to have a good fluid intake to decrease urinary tract infections, and also it can cause constipation if there's not enough fluid intake. Same for people that don't have spina bifida. Sometimes these patients are less mobile, so that can be part of what causes their constipation and fecal issues. Sometimes we'll give them fiber supplements. It gives more volume to the stools, which makes the transit easier to control. Of course, we have to have a good elimination routine. We start this early with children. So the routine is to at least sit down every day at a regular hour. What we recommend is after dinner. Because after eating, this stimulates the bowel, so it's a good time to try to empty the bowel. For young children, the perineal or anal stimulation can help parents learn this. So a small massage on the perineal area will stimulate the rectum and will cause a contraction and the stool will pass. Some patients, even if it's not frequent, will use rectal curing. When we have physical limitations, or for young children, they can't do it themselves. So for children, parents do it. I have a patient with whom I'm working since 1991. She was a child when I started caring for her. I was a resident. Now she's in her 30s, and she's always used rectal curing, and there's never any stool leaking. She's just mobile enough to do it herself every day. When she was a child, her parents did it, but now she does it herself. So it can work very well for some patients, and no leakage for her. So it's not the most popular method, but you can think about that. She has no complications. So you just have to get over this idea of inserting your fingers and manipulating your stools, but it works pretty well. Then there's medication, pharmacological treatments. There's many categories. Some we use more for children and less for adults. So lubricating laxatives are more used for children, like mineral oil or a mineral oil jelly, which is called Lansoy. It works well for children, for babies that are still wear diapers. But if we use too much, it causes malabsorption and belly aches. For older children or adults, when you wipe After going to the bathroom, it's more difficult because there's oil, so it's more difficult to get cleaned up after. So patients don't like it because they feel like they're still dirty. So when they use mineral oil on a regular basis. Other laxatives, we have stimulating laxatives that have a chemical effect on intestinal function to increase the transit and stimulate the colon. There's many of them. The most popular nowadays is polyethylene glycol. There's many types, many brands. Laxaday is one, but many other companies create this medication. The idea is that not to cause a dependence. Many of them cause dependence. So if you use it in a chronic way, but with a neurogenic bladder with spina bifida patients, sometimes you don't have a choice. You have to release the stools in some ways. So they have to use medication in a chronic, regular way. We can't stop it after 2 or 3 months. When it works, they will take them as long as our treatment plan works. So Laxaday is one of the ones that we use the most, very little side effects. But sometimes it's just, the issue is just adjusting the dose to making the stools soft enough so they're evacuated, but not too soft so that it becomes diarrhea, because with people that have issues with the sphincter can make the incontinence worse. We also have Bisacodyl, an oral medication, but that can also be a suppository. Can be useful. Milk of magnesia we don't use as much. Glycerin can be practical. It's an oral medication, but can be a suppository as well. It can be combined with other stimulants. It is a stimulant. For the rectum, it's a sugar that dissipates in the rectum and stimulates it a little. What's useful is that when we insert it, we know that in the next half hour, normally we'll have to pass stool. So we can sit on the bathroom, on the toilet. It's easier than using polyethyl glycol. It softens stools, but does not always necessarily come out when the patient wants it to. Sene is a plant extract called also Senokot, is often used. Comes in many different forms, gel, capsule, syrup, very versatile. The only disadvantage is that it can cause cramps, stomach aches. So people with spina bifida sometimes have less sensory feelings, so it can affect them, but it's very useful.
After this, we can go with, we can also go through the mouth, but we can also use intrarectal approach. It's not always easy, but when it's kids and parents are there, the manipulations can be done by the parents. But when we're an adult, it depends on how we are, and usually people want to be independent, and it really depends on the level of disability. Are they in a wheelchair? Can they do manipulation? do they have a manual limitation? So this is not for everybody, because sometimes it requires to have help in order to use the intrarectal approach. A lot of the adults are not totally autonomous. They live in an autonomous way, but they have help at home. There's glycerin, the bisacodil, that's also a stimulant, can be used as a suppository, and it can be combined with intrarectal stimulation. There's also enema. There, Microlax, it's very efficient. Now it's out of stock, but we hope it will come back. There's a little ampulla. It's a little bit like the fleet enema. We have them in pediatric or adult doses, and patients respond well to them. The advantage of enema, we decide when we do them, so we have a certain independence, and we know when we will have a stool movement, intestinal movement, or so we can sit on the toilet. And once we've eliminated part of the stools, and there's the patient knows that they can have a good period without risk of incontinence. Very often we combine these treatments. We can do enema and then take oral medication as well. We can take polyethylene glycol and maybe enema every 2 days and suppository every 2 days. So the recipe changes and varies depending on the patient, and sometimes it's trial and error, and it depends on the physiopathology of the a patient, and not all spina bifida are alike, right? So there's a whole spectrum of malformations, more or less severe. So we really adjust the treatment uh, according to the patient. So if we have oral medication, and or if we see that something is not working, we can use more advanced methodologies, methods. One of the most common is retrograde colonic irrigation. So we put the cannula in the rectum. There is one on the market that's called the Peristeen, and once it's in the rectum, we can pump water in the rectal part of the intestine, and then we can discharge part of this of the intestinal. So a lot of the patients who have done this will be 24 to 36 hours without having to do anything. So it's a big advantage because it's not really medication, it's partly mechanical. So it can be done by the patient, him or herself, with minimum of help. The pump to introduce the liquid can be controlled by manually, and the patient can be sitting on the toilet. So it's really easy to teach as well. So we have our nurses at Saint Justine and at the CHUM who can teach it to the patient the first times. And patients are really satisfied actually with this method. But for certain patients, it's not easy. And if they're taller, bigger, they cannot manipulate it easily. So there are other methods as well that we can use if Peristeen cannot be used or will not work. The two other methods that are significant, we've been using them for many years. They're called antegrade enema. So we discharge the whole intestine. So there are two ways to do it. We can use a cecostomy button, or we can use Malone or Monti procedure. These are two variations of the same principle. So the Malone, we take the appendix on the and then we bring it to the skin. It's a small surgery. And once this is branched to the plug to the skin, the patient can just do a catheterization. And most of the patients do it already with the bladder, so they're used to doing it. And the catheter is the same one. And they have a irrigation system that they plug to their catheter for 45 minutes. And we use a saline solution of up to 1 liter. And it can be made at home using tap water. Some people prefer to use boiled water, but it's not necessary. We can use tap water. That's perfectly fine. Usually people do it in the evening. They sit on the toilet, and they within 45 minutes they can discharge the whole intestine. So the advantage of doing this in all integrity is that since we discharge and the whole intestine, then we can go on for maybe almost 2 days without doing it. The cecostomy button, the second image here, has the advantage that it doesn't require surgery. It's done with radiology and imaging, so it's not as invasive, but it's a little button that's visible on the skin. Some patients don't like it. But when it's an appendix, we can put it in the belly button or in a way that it's not seen on the skin. But the two systems work very well. And it's the same principle for both of them. And they can be used for a long period. And it can be also combined with medication, irrigation. There are a lot of ways to empty the colon. For some patients who have a more severe disease, the colon can deteriorate. Sometimes it can accumulate a lot, and it can stretch out and expand, and it's not as functional. And sometimes we need to do a surgery to either shorten it, or sometimes for certain patients, we have to empty the stools in a little bag. But that's really a minority of people. Most of the time, we can actually resolve the problem with all the methods I've illustrated in the slides. So this is pretty much what I wanted to say about the stools from a point of view of a urologist who works with pediatrics and adults. As a conclusion, I'd like to say that the care of a patient with spina bifida is lifelong, and people now have a long life expectancy, almost the same as someone who has no disease. And we have to remember that bowel function and bladder can change throughout the life, and it's important to do regular checkups and follow-ups. So transition is actually an utmost importance in this regard. And of course, if we manage well stool elimination and urines, we have to do both, as you can imagine. We don't want to have a patient who is incontinent on the urinary level, but continent with stools. So we want to reach a quality of life that's as optimal as possible, and give as much autonomy as possible to patients. Thank you very much.